If you've been taking a blood pressure pill every morning for months, maybe even years, Amlodipine, Losartan, or Lisinopril, let me ask you something most people never stop to ask themselves. How sure are you that you really understand what that pill is doing inside your body right now? Not the one-line summary on the bottle, not the rushed explanation from a busy office visit. I mean, truly understand it. What it changes, what it can quietly affect over time, what symptoms are usually manageable, and which warning signs should never be brushed aside. Because here's what I have learned after speaking with so many older adults. Most people taking blood pressure medication are not careless. They are not irresponsible. In fact, they are often the exact opposite. They are disciplined. They are routine-driven. They take their tablets on time. They keep their appointments. They try to eat better. They try to do everything right. And still, many of them are taking powerful medication with only a partial understanding of what to watch for. That matters more than people realize. These are not harmless little pills. These medications affect blood vessel tone, kidney function, fluid balance, and the chemical systems that regulate pressure inside your body every single day. And when you do not understand how your specific medication behaves, it becomes very easy to miss what your body is trying to tell you. Today, I want to fix that. My name is Dr. Clara Hoffman, and on this channel, my goal is simple: to give you clear, practical health information in plain language so you can protect yourself, ask better questions, and feel more confident about the medications you take. By the end of this video, you will understand Amlodipine, Losartan, and Lisinopril in a much more useful way. Not just what they are called, but how they differ, what they commonly trigger, what mistakes people make on them, and what warning signs deserve real attention. And I want to begin with a situation that plays out more often than most people think. Imagine a 75-year-old man who has been taking his medication exactly as prescribed. He is organized. He does not miss doses. He trusts that if his doctor gave him the medicines, then any change in his body would probably be unrelated unless it was dramatic. A few months after starting Amlodipine, his shoes begin to feel tighter by late afternoon. His socks leave marks. His ankles look puffy. His legs feel heavier at the end of the day than they used to. He starts walking less because it feels uncomfortable. Then the worry begins. Is this heart failure? Is my circulation getting worse? Are my kidneys shutting down? Now imagine another person, a woman in her early 70s taking Lisinopril. Several months go by, and she develops a dry cough that seems to come from nowhere. Not a chest cold, not mucus, just an irritating, scratchy, stubborn cough, especially at night. She blames allergies, then reflux, then weather changes, then dust in the bedroom. She tries lozenges, water, sleeping more upright. Nothing solves it. Now imagine a third person on Losartan who decides to make a healthy change. He cuts down on salt and switches to a salt substitute from the grocery store. It looks like a heart-smart decision. It sounds like exactly the kind of thing doctors would want, and yet, without realizing it, he may be creating a problem that could affect the rhythm of his heart. These situations look completely different on the surface, but they all come from the same misunderstanding. People hear blood pressure medicine and assume these drugs are basically interchangeable. Same purpose, same category, same concerns. They are not. Amlodipine, Losartan, and Lisinopril all lower blood pressure. That is where the similarity starts. It is not where the story ends. Amlodipine is a calcium channel blocker. It relaxes the muscles in the walls of your arteries so blood can move with less resistance. Lisinopril is an ACE inhibitor. It interferes with a hormonal pathway that normally tightens blood vessels. Losartan is an IARB. It works on that same overall blood pressure system as Lisinopril, but it blocks the signal at a different point. 3 different mechanisms, 3 different side effect patterns, 3 different kinds of misunderstandings, 3 different things a senior needs to recognize early. And once you understand that, your medication stops being just a name on a label. It becomes a pattern. And patterns are what keep people safe. Let's start with Amlodipine because one of its most common problems is also one of the most misunderstood. Swelling in the ankles, feet, or lower legs. A lot of people see swelling and immediately assume the body is holding water in some vague general sense. Or they assume the heart is failing, or they think their kidneys are suddenly getting worse. Sometimes that is not what is happening at all. With amlodipine, the issue is often mechanical. This medication relaxes arteries very effectively. Blood moves into tissues more easily. But the veins do not always adapt in the same way. So what can happen is that pressure builds in the tiny blood vessels near the lower legs and ankles, and some of that fluid shifts into the surrounding tissue. That is why people often notice puffiness that becomes more obvious later in the day. Shoes feel tighter, socks leave grooves, legs feel full or heavy. The swelling may improve overnight after lying down, then return as the day goes on. Now here is where the real problem begins. Not always the swellings itself, but how people react to it. Some people get scared and stop the medicine on their own. Some people start drinking less water because they think they are somehow too full of fluid, which can push them in exactly the wrong direction. Some people simply tolerate it in silence for months, walking less, avoiding outings, feeling older and weaker than they really are. And that quiet reduction in mobility matters. The more people avoid activity, the more balance, strength, and confidence they can lose. So the right message is not panic. The right message is attention. If you take amlodipine and your ankles or feet are swelling, especially if it is persistent or getting worse, that is something to report. It may mean the dose needs review. It may mean the timing needs adjustment. It may mean a different medication would fit your body better. But the answer is not to guess alone and hope it sorts itself out. If you take amlodipine, I want you to remember this simple line. Swelling is information, not something to hide, not something to automatically fear, but definitely not something to ignore. Now let's move to lisinopril, because this one has a side effect that drives people crazy, precisely because it often seems unrelated. The dry cough. Not a wet cough, not a cough with phlegm, not necessarily a cough that starts right away. This is often a dry, tickling, nagging cough that lingers in the throat and can be especially frustrating at night. It may appear days after starting the medication. It may appear weeks later. In some people, it shows up months later. And that delay is exactly why so many people miss the connection. They think, if my medicine were causing this, wouldn't it have happened right away? Not always. That is what makes lisinopril tricky. A person may spend months chasing the wrong explanation. Maybe it is pollen, maybe it is dust, maybe it is reflux, maybe it is the weather, maybe it is a cold that never fully left. Meanwhile, sleep gets worse, energy drops, frustration builds, and nobody connects the dots because the medication feels too old to be the culprit. But sometimes it is the culprit. And when that link is finally recognized, the relief can be surprisingly fast once the medication plan is reviewed with a doctor and changed appropriately. Now, I need to draw a very sharp line here because with lisinopril, there is a difference between a side effect that is annoying and a side effect that can be dangerous. A persistent dry cough is something to discuss. Swelling of the lips, tongue, face, or throat is something entirely different. If someone taking lisinopril develops swelling that affects the mouth, tongue, throat, swallowing, or breathing, that is not a wait-and-watch moment. That is urgent. That requires immediate medical attention. This reaction is uncommon, but it is real. And one of the reasons it is so important is that people often underestimate swelling when it begins. They think they can observe it. They think maybe it will pass. But when the airway is involved, delay is not a safe strategy. So for lisinopril, there are really two separate lessons. A dry cough may be the medication, but facial, lip, tongue, or throat swelling is an emergency. Please keep those two categories separate in your mind. Now let's talk about Losartan. And actually, this next point matters for Losartan and lisinopril more than most seniors realize: potassium. A word many people barely think about until someone tells them their blood test was off. Here is the issue. Losartan and lisinopril can affect the body's handling of potassium. For many people, that never becomes a serious problem because they are monitored appropriately. But trouble can start when medication meets hidden sources of potassium that people do not think to mention. And one of the biggest examples is salt substitutes. A senior gets told to cut back on sodium. That sounds sensible. They go shopping. They choose a product marketed as a better option for the heart. It may look like a healthy, responsible switch. But many of these substitutes replace sodium with potassium chloride. So now the person is seasoning meals regularly with extra potassium while also taking a medication that can push potassium upward. That combination can become risky. And what makes high potassium especially deceptive is that it does not always announce itself clearly. Sometimes the clues are vague: muscle weakness, unusual fatigue, cramping, tingling, a fluttering or irregular heartbeat. Sometimes symptoms are subtle. Sometimes there are almost no obvious symptoms until the problem becomes more serious. That is why I want you to think bigger than just bananas. Potassium may be hiding in salt substitutes, certain electrolyte drinks, powders, supplements, and some over-the-counter products people assume are harmless. If you take Losartan or Lisinopril, your doctor should know about those products too. Not because those medications are bad, not because healthy eating is wrong, but because chemistry does not care about good intentions. And that leads to one of the most overlooked blood pressure medication conversations of all. What happens when you get sick? I am not talking only about a medical emergency. I am talking about ordinary real-life illness, a stomach bug, vomiting, diarrhea, several days of poor appetite, a hot stretch of weather when you are sweating more and drinking less. Even a few days of dehydration can change the way blood pressure medication affects your body. This matters especially with Losartan and Lisinopril. When you are dehydrated, blood pressure can drop more easily. Kidney function can become more vulnerable. The same dose that felt perfectly fine when you were well hydrated may suddenly feel too strong in a body that is depleted. And that is when people can get dizzy, weak, lightheaded, faint, or run into kidney trouble faster than they expected. The medication did not suddenly become evil. The environment inside the body changed. That is a very important concept. Illness changes the rules. And if nobody has ever talked to you about what to do with your blood pressure medication when you are vomiting, having diarrhea, barely eating, or unable to keep up with fluids, then there is a gap in your safety plan. That does not mean you should start making medication decisions on your own. It means you should already know whom to call and what guidance your own clinician wants you to follow if you get sick. A sick day plan is not extra information. For many seniors, it is essential information. Now let's move to another problem that catches people off guard because it starts with something ordinary: pain, a sore back, arthritis flaring, an aching knee, a stiff shoulder. So you reach for something familiar from the drugstore: ibuprofen, naproxen, a common anti-inflammatory. Something millions of people have taken for years without giving it much thought. But when you combine certain pain relievers with medications like Losartan or Lisinopril, especially in older adults, and especially if dehydration or a diuretic is also in the picture, kidney stress can become much more likely. This is one of those situations people underestimate because the medicine came from a shelf, not a prescription bottle. But your kidneys do not care where the medication came from. Prescription or non-prescription, they respond to the effect. So if you regularly take anti-inflammatory pain relievers and you are also on Losartan, Lisinopril, or even a broader blood pressure regimen, this is worth discussing with your doctor or pharmacist. There may be safer alternatives depending on your health history. The key point is not that every dose is catastrophic. The key point is that routine, casual use without realizing the interaction can be a real problem. And now I want to talk about something many seniors dismiss because it feels too small to report: dizziness when standing up, that little wave of lightheadedness when you get out of bed, that brief wobble when you rise from the sofa, that moment when you instinctively reach for a wall, a chair, or a countertop before the feeling passes. People brush this off all the time. I stood up too fast. I'm just tired. It only lasts a second. But in an older adult, a second can be enough. A second of lightheadedness can lead to loss of balance. Loss of balance can lead to a fall. A fall can lead to a fracture. And a fracture, especially later in life, can change everything. This is why blood pressure treatment is never only about numbers on a monitor. It is also about how you feel moving through your day. If your medication lowers pressure so aggressively or interacts with your hydration status in such a way that standing up becomes a regular unstable event, that deserves review. Sometimes the solution is practical. Stand up more slowly. Sit at the side of the bed for a moment. Pause before walking. Hold on to something stable. But if the dizziness is frequent, worsening, or associated with near fainting, that is not something to silently normalize. That is a conversation. Because a small symptom can be the first visible sign of a much bigger risk. Let's also clear up something that creates a lot of unnecessary panic at home. One blood pressure reading is not your whole story. Blood pressure changes throughout the day. Poor sleep can affect it. Pain can affect it. Caffeine can affect it. Anxiety can affect it. Rushing in from outside can affect it. Even worrying about the number while you are checking it can affect it. So when someone gets one high reading and immediately assumes their medication has failed, or one low reading and assumes the medicine is suddenly too strong, they often make poor decisions from a single moment that lacked context. They skip doses, they take extra doses. They get frightened by numbers that are not being interpreted properly. What matters more is the pattern. Same arm, similar time of day, after sitting quietly for a few minutes, repeated over time. Patterns help doctors make decisions. Panic does not, so monitor carefully. Log readings consistently. Bring the trend, not just the most alarming number, to your appointment. That gives your doctor something far more useful than a rushed reading taken after stress, movement, or worry. And if you are getting value from this so far, take a moment and tell me in the comments which one you take, Amlodipine, Losartan, or Lisinopril. I read those comments, and it also helps me know what information people need most. Now, there is one more mistake I need to talk about because it creates trouble quietly: inconsistent use. These are not medications that work best in a chaotic pattern. They are meant to create steady control over time. That means missed doses, doubled doses, or jumping around with timing can confuse the picture more than people realize. Some people miss a pill and then take two later out of fear. Some stop for a few days because they feel okay. Some take extra because one reading looked high. That is not how these medications are meant to work. They are not rescue medications. They are stability medications. And when stability turns into guesswork, the body feels it. Blood pressure can swing. Symptoms can appear more dramatic. People conclude the medicine is not working, when in reality, the pattern of use is the problem. So if you have ever been unsure what to do after missing a dose, that is not something to improvise in the moment. Get clear instructions from your own prescriber and keep them somewhere easy to find. That kind of planning prevents bad decisions on the exact day you are most likely to make one. Now, I want to close with what I believe is the most important idea in this entire conversation. The best blood pressure medication is not simply the one that lowers a number. It is the one that lowers blood pressure safely, predictably, and in a way that still allows you to live your life well. If a medicine controls the number on paper, but makes your ankles swell so much that you stop walking, that matters. If it causes a cough that ruins your sleep for months, that matters. If it leaves you dizzy enough that standing up feels risky, that matters. If it interacts with your salt substitute, dehydration, pain relievers in ways no one ever explained to you, that matters. Side effects are not a sign that you are failing. Symptoms are not a character flaw. They are information. They are your body's way of reporting back on the treatment plan. And one of the biggest mistakes seniors make is assuming they have to suffer silently just because the medication is important. Important does not mean untouchable. There may be dose changes. There may be timing changes. There may be better alternatives. There may be combinations that suit your body more comfortably, but those options only become visible when you speak up. So let me leave you with a simple framework. If you take amlodipine, watch for ankle or leg swelling, especially later in the day. If you take lisinopril, watch for a persistent dry cough and treat swelling of the lips, tongue, face, or throat as urgent. If you take losartan, be careful with hidden potassium sources like salt substitutes, and know that vague symptoms like weakness or palpitations should not be brushed aside. With all three, rise slowly, pay attention to dizziness, avoid casually mixing in anti-inflammatory pain relievers without guidance, monitor blood pressure by pattern instead of panic, and make sure you know what your doctor wants you to do if illness, dehydration, vomiting, or diarrhea suddenly changes the situation. And most importantly, never stop or change a blood pressure medication abruptly without speaking to your prescribing clinician. You watch this because you care about your health. That already puts you ahead of the people who take these medicines on autopilot and hope for the best. My goal is not to leave you fearful. My goal is to leave you clearer, because clarity changes everything. It turns a pill into a plan, a symptom into useful information, a vague worry into the right question, and a silent risk into something you can catch early. If this helped you, share it with someone taking blood pressure medication, especially an older parent, spouse, sibling, or friend. This is exactly the kind of information people often do not get until after a problem begins. And if you want more practical health guidance explained in plain language, stay with me. I'm Dr. Clara Hoffman, and I'll see you in the next one.